will for change, the will to develop a new system, to improve something, to do it a different way tomorrow, has to come from the senior leaders of organizations and political systems who say, wait a minute, everybody, it's very important that we, in this case, improve patient safety, and I'm going to provide you with the time and the support and the encouragement and the celebration that makes it possible for you to work on your work, to change your work. Senior leaders create a context in which the people that do the work can change the work.
By going upstream and concentrating on the things that provoke error and make it serious when it happens, strengthening the system, we can reduce those risks systematically.
Most errors are caused not by bad people but by bad systems. And this is really an amazing insight for healthcare.
The system approach is clearly the most sensible approach because it deals with the defences and the barriers and the safeguards. And this approach has been widely endorsed by the Institute of Medicine, the Department of Health, the Australian government, the Canadian government, and so on. And it's entirely proper that that should be so, because blaming, naming, and shaming, they may make us feel good, but they have absolutely no remedial value.
90,000 deaths per year in American hospitals. Well, how did we get there? We got there by allowing our systems, the systems for delivering care, to grow in an amorphous manner that has ultimately led them to have an illness all their own. So in a sense, you have sick patients coming into a sick system.
We looked and found that 3% of all of our patients were scheduled incorrectly for surgery. So what we did to correct that problem was to standardize the way in which all operating room cases are scheduled. To do that, we created a standardized form. We were able to put that onto the computer so that the surgeon can electronically schedule the case. Prior to that, it had been done by a number of phone calls. Pieces of information would be lost through the number of handoffs through these communications. We will soon be able to measure the effect of this and look at the reduction of cases that are booked incorrectly.
We've established a National Patient Safety Agency to provide leadership and also to carry out some of the vital technical functions which are necessary to improve patient safety, gathering information through a reporting system, analysing the root causes of things that have gone wrong, and then coming up with the sort of solutions which, if they're implemented throughout the National Health Service, will systematically reduce risk and ensure that the bad experience or the life lost by one patient perhaps saves the life of another patient in the future.
The 7 Steps is a single document that brings together all the theory and all the research on patient safety, which then provides take-home messages and practical solutions for which you can make a difference locally. Step 1 is about building a safer culture, and that's about an individual saying, how safe am I? And an organisation asking, how safe are we? And providing the tools and techniques in which to make a difference and measure that, monitor it, and make changes. Step 2 is about leadership and support, and that's about the leadership at the top of the organisation as well as throughout the organisation. Leaders of teams, leaders of practices. And what we expect to happen here is that they will ensure that their teams are safe and that they are able to speak out when they are concerned when things go wrong. Step 3 is about integrated risk management. And what we mean by that is, currently, when things go wrong, such as complaints or claims or incidents, they're all dealt with separately throughout the organisation by separate people. And in order to really know what's going on in your organisation, you need to bring those together, and we call that integrated risk management. The other aspect of integrated risk management is to ensure that you integrate your risk assessment processes. So what we mean by that is that you risk assess the things that you do, the work that you provide, and you bring all of that together into holistic risk register, and then you will truly know what your organisational risks are. Step 4 is a fundamental step. It's about promoting reporting. If we don't know what's going wrong, we cannot do anything about it. And so promoting reporting is about local reporting, which feeds into local systems, which in turn feed into our national reporting and learning system. Step 5 is about engaging our patients and public. And what we mean by that is communicating what risk means, and also making sure that they affect their own safety, but also about informing them when things go wrong. And we call that being open, about saying sorry, about acknowledging the error, and about doing something about it. Step 6 is about sharing and learning. So we're building on all of the other steps. We've developed our culture, we've promoted reporting, we've engaged our patients, and now we want to share and learn all of those lessons. And the tools that we promote here are root cause analysis and significant event audit. Step 7 is about generating solutions. What we want to do here is design out error so that we can reduce harm. And what we do is generate solutions which are realistic and sustainable, and that way we know we can really make a difference.
The objective isn't to make perfect people, it's to keep those mistakes from hurting people. Pilots make mistakes, but planes don't crash very often. We want to do the same in medicine.
Some errors are indeed egregious errors. They are indeed reckless errors. And to some people, an excessively systemic approach could be seen as a blunderer's charter. So in healthcare, more than any other hazardous domain, we have to recognize that it has unique features. It's very much a one-to-one or a few-to-one kind of culture, where it really matters whether people go the extra mile, where the person is a very significant factor. We need to consider a more balanced approach between the wild excesses of naming and blaming, as in the person approach, or even the extreme system approach. We have to try and find a middle ground in which the person is given skills to recognize error provocation, to recognize tasks that can cause them to go wrong, where they can behave in a vigilant and wary fashion.
The degree of complexity in our ability to deliver care, to make diagnoses, to institute therapies, just burgeoned. The result was that hospitals kept on having to add on these little pieces one by one as each new kind of therapy developed. You'd buy the building next door, put a bridge to get over to it, and then another building after that. The delivery of care in those systems has become as complex as the geographic distribution of the organization. And it's become so complex that it eventually has become unruly and unmanageable.
We need to commit to invest in safety, investing time and energy, technology. You don't get it for free, not at the start, and we have to allocate resources to make our patients safe.
Can anyone come up with some of the other potential factors that exist?
No matter how well trained somebody is in medicine, it's surprising how often things can go badly wrong. So we're now creating these standalone simulation units.
Hey George, how are you? Okay, let's just get you a little bit of oxygen, that'll help with your breathing.
Which provide as high a fidelity mannequin as we can. It's currently the highest available in the world. So the closest thing to a little boy or girl and an adult. So we can send in a group of doctors and nurses and healthcare assistants into the simulator to look after a critically ill child and have them doing their everyday function, but then add some form of human factor element into it. And by way of these television monitors and all the cameras in the ceilings and radio mics, we can really focus in on the interaction within that team and then play it back. We can throw in some nasties and tell the computer that if given a particular type of drug or antibiotic, he will respond with an anaphylactic reaction.
Can I have some help, please? Anaesthetist to bed 6.
And this has changed teaching completely, that we're no longer having to have somebody explain that, you know, you did this, and actually they can't quite remember that they did that. So they walk away thinking, well, that person's just picking on me. Whereas we can play back a video showing them exactly what they were doing at a critical point, and they can take it on board themselves. Nobody has to point it out to them. And this self-reflected learning is a hugely powerful tool.
You get information saying that there's been an adverse drug reaction, there's been a hemorrhage, in serious hemorrhage of the patient, things like that. Now, on its own, when it's aggregated this data, it tells you that there's a problem area, but it doesn't on its own tell you very much more. What it's best viewed as is signals. They're flags that something is happening. The real purpose of the incident investigation is not to find out what happened. It's to reflect on what the incident tells you about the system in which you're working.
It's better for us to know about a risk than not to. Therefore, everybody at every level is encouraged to report risks, which they can do anonymously or they can do via the formal structures of reporting on clinical incident forms, accident reports and the like. So the idea is very much that it's not about whether a person feels that something is important. It is very much about assessing that risk objectively.
Medical and nursing staff are expected to prepare injections in the clinical areas. These areas are not always best designed for this purpose, and the training and processes that medical and nursing staff use are sometimes variable. And so unlabelled syringes and unlabelled infusions can be laid to one side and administered to the wrong patients because of lack of clarity of procedure and process.
Well, you have to have a safe places for nurses to work. In order to have a safe place for patients to heal, they cannot one without the other. They're paired.
We're trying to make it very easy for people to report, because one of the barriers is just that it's time consuming and people are very busy and don't have time to do it. So we're actually planning to implement a reporting system that's on the web and that's very quick and easy to use, hopefully only 2 minutes to do a report, and so that will increase the frequency of the events that we hear about. Also, it will promote hearing about actual events and near misses.
29,000 staff took time out of their busy schedule to let us know what went wrong and their views on how it could be put right. So I think it's often a knee-jerk. People say, oh, staff are too busy. Our experience is, actually, they were desperate to us.
Performance in a system, like safety as a feature of performance, is a property of the design of the system, like the speed of a car is a property of the car. If we want things to be safer, we have to redesign the work, redesign the system in which people work.
Just occasionally, it's possible to do this from the ground up.
What we wanted to do was build something that we could try here. We could try a process, a technology, a piece of equipment, and see if we can make it work well in this beautiful new environment. Then that's something we could transport to our other medical units.
We have a camera which can operate in infrared, so it can take photos in absolute dark. It can detect some areas, so if the patient will try to fall out of this area, the camera will be able to send an alarm.
Suppose a doctor pops out of a surgeon's room or an operation theater and only has 15 minutes in which he can attend to, say, top priority or top two risky patients. This software can do a ranking of the patients based on their physical condition. He could immediately walk up to those two patients and then get back to his work.
It's designed for having to increase patient volumes very, very quickly. For example, an infectious outbreak such as SARS, where we have to not only have beds available for patients from the community, but we want to limit spread of the disease in the hospital.
Every patient can have their own toilet.
We've got additional space for a second bed here. We also doubled up on the ancillary features for oxygen, for patient monitoring, and for providing the services we need to.
The changes we made came from nurses who walk into a room and know that they need the oxygen outlet to the left and they need the suction to the right. They need a big footprint to get around the bed. And the physician saying, I need this piece of equipment in order to teach another physician. We've taken bits and pieces from the people that 100% of their job is to care for patients.
The real jugular issue is that of design. Is making sure the systems that we develop, the practices and procedures that we apply conform to good practice, are open to critical, constructive examination and are amenable to correction when that's required, in an atmosphere of trust and confidence.
But we have to recognise also that the system approach, if taken to extremes, can also have its shortcomings. One of the shortcomings is the feeling of learned helplessness that people at the front end of the system, the nurses, the junior doctors, must feel. They are not in a position to change the system. So if the system approach were to be too dominant, they'd be inclined to say, well, what can I do? It's the system.
We're all trained in healthcare to be individually competent, to be able to do our jobs well. We're often not trained in the systems aspects of what we do, no systems training, and many of us are placed in charge of those systems and asked to do something about them and not really understand what it is and how to do that. Many folks hide behind that competency, that individual competency that they have and say, I'm okay, it's the system that's wrong.
There is no doubt that we're in evolution here. This is a journey. Our medical system in this country, as in many others, is stressed beyond belief. We are space constrained. We are financially constrained. We are confronted with an aging and increasing population that are putting demands on those constrained resources, so that the throughput, the pace, and the emerging technology all provide an increasing environment ripe for error.
The work itself is multidimensional. You are not going to be able to just work on high-risk meds or just work in technology or just work in communication. It's all of those things. And I think, too, it's the ability to appreciate that safety is a property of every system you work on. You're not going to put on your hat today and say, I'm going to work on safety. Every time you work on training, every time you work on communication, on processes with families, every one of those is an opportunity to think about safety.
In order to cope with that, we're going to have to sustain this effort very diligently, year after year, and incorporate the latest technology to help us cope with that increased population, that increased throughput, with a fixed amount of staff in all probability and a fixed amount of finances in terms of the percent of our GDP allocated for medical care.
There need to be error management measures at every level of the organisation, for the individual, the team, and the institution as a whole.
Oral liquids sometimes have to be drawn up into syringes in order to be measured and to be administered. And up until quite recently, there have only been intravenous syringes that would be available for this purpose. And so oral medicines, popular oral medicines like Calpol, paracetamol, Senecot syrup, have all been drawn up into IV syringes intended for the oral route. But because the IV route has been available, oral liquids have been administered by the intravenous route. And again, the MPSA is working on a connector solution for this to ensure that only oral syringes are used for oral liquids, and the connectors for these oral syringes will not fit any other route of administration.
Patient dependencies are recorded every day by every ward, and a trained nurse within that ward undertakes the recordings. Every patient is categorised into a dependency ranging from a dependency 1 down to a care group 4, whereby the needs of that patient needs to be met by a trained nurse through a 24-hour period. From a daily point of view, it allows me to make the decision ultimately about whether to move staff from one area to another, and the rationale being patient dependencies is then fed back as the reason to the nurse who's actually asked to move. Because in the past, sometimes nurses believe that their wards have always been busiest and the most demanding. So I think this information allows people to make objective decisions.
This is a simulated operating environment. The main drivers for this is how do we train multidisciplinary team. Operating theatres have become very complex environments with the introduction of new technologies, new procedures, a lot of innovation. If we do not train the staff and the workforce and install the team spirit within those staff, the likelihood of clinical incidents and clinical errors is on the increase.
We are going to create a crisis scenario for the surgeon, namely bleeding.
When I start the bleeding from the control room, the surgeon will face a copious amount of bleeding from his operative site. This is one of the most harrowing experiences a surgeon can face.
Really struggling at the moment.
The danger really is that people will purely take a league table approach to this and not compare like with like. If you measure outcomes based purely on crude data, you will get some very misleading information.
We live now in an age of transparency when it comes to information. Now, there is a danger in this, both to the patients and to the surgeons. The danger to the patients is that if we monitor by crude outcomes alone, say for example operative mortality, then that is likely to put people off offering patients who are at high risk surgical treatment. The problem with this is actually quite a serious one, because unfortunately in cardiac surgery there is a bit of a paradox in that the more dangerous the operation, the more likely is the patient to benefit from it. And of course the risk to the surgeons is that if they are being monitored by crude outcomes, then they may either be penalized simply because they do operate on high-risk patients because they want to offer their patients the best, or they may end up having a very protective practice.
We've developed quite a robust risk stratification mechanism for the monitoring of cardiac surgery. What we use is a tool called Euroscore. What it does is take into account all the comorbidities that a patient arrives with. So things like their age, their gender, whether they have hypertension, whether they've got poor circulation in their legs, whether they've had previous heart attacks, all those kind of things, and scores them because they are things that have been proven to contribute to mortality following open heart surgery. What we have done, therefore, is we have a predictive tool that actually gives a hard figure that we would expect a patient's survival or mortality to be.
Now, whenever you are looking at whether it is a good idea to offer someone an operation to make them live longer, you've got to look at what is the risk of the operation itself, so you can weigh that against the benefit. And if you don't have an idea what that risk is, then you cannot come to a sensible conclusion.
What we use the Euroscore tool for is an indicator that something may be going wrong rather than a determinant that something has gone wrong.
You're not going to get to a point and declare yourself safe. You're going to get to a point where you're safer, and then you have to think about how you're going to hold those gains that you've made and continue to be vigilant in the environment, because every new piece of equipment, new staff, new technology, changes in the environment, each one of those present safety risks and hazards. And so I think the dedication to not see this as a project, but to see this as a lifelong commitment that's going to require systems improvement and vigilance over time is something that we've yet to see.
Up until now, the performance of the National Health Service has very much been judged on reducing waiting lists and hitting targets and getting financial balance. All of those things are still very, very important. But I'd like to see us move to a position where a chief executive is judged as well on the safety of care provided in their hospital, and their performance and their day-to-day activities are orientated towards achieving that safety goal, to sit alongside the financial targets and the activity targets that they have to achieve.